Hello students. So in this series we'll be discussing some important questions and topics from dermatology. So let us begin with the first question. Here they are saying that 22-year-old male presented with an asymptomatic scaly lesions over his back, symmetrical in distribution. So the distribution of these scaly lesions is symmetrical as shown below in the image. Identify the disease and the pattern of the lesion. Now if you see that there is trunk involvement and over trunk the lesions are symmetrical. And if you closely see these lesions, there is one erythematous lesion and it is having this scaling which is at the periphery. So all these points are suggestive of which condition? Pityriasis rosea. As you can see in pityriasis, there is scaling which is seen and the scaling is characteristically around the lesion. So it is looking like a collar. So collarate scaling is seen and this is a fir tree appearance, that is symmetrical distribution of the lesion. So all these are pointing towards pityriasis rosea where Christmas tree pattern or fir tree pattern and collarate of scales are seen. So this is the correct option. Now remember that Wickham striae is seen in lichen planus. So it is seen in lichen planus, but it is what? It is a reticulate pattern which is seen over the lesions of lichen planus. Similarly, Christmas tree pattern is not seen in lichen planus, it is seen in pityriasis rosea, and Warnoff ring is not seen in seborrheic dermatitis, it is seen in psoriasis. So this is one hypopigmented margin of the ring which is seen around the lesions of psoriasis. Okay, so pityriasis rosea is one important condition and sometimes these related questions are asked. Then here this is match the following, and here they have given some Woods lamp finding. Okay, so Woods lamp finding of certain conditions are very important, like erythrasma where coral red colored fluorescence is seen. So coral red fluorescence is seen in erythrasma. Then in pityriasis versicolor, you will find yellow or apple green fluorescence. So yellow or apple green fluorescence is seen. In tinea capitis, green fluorescence is seen, or sometimes it is also referred to as bluish green. And in vitiligo, it is milky white, while pink fluorescence can be seen in patients suffering from porphyria. So these are few findings which are important under Woods lamp examination. So the correct answer becomes second. So first erythrasma, that is coral red. Then second pityriasis versicolor, that is yellow fluorescence. Then tinea capitis, blue fluorescence, and vitiligo, that is milky white fluorescence. Moving to the next question, here they are saying that a female developed a skin reaction after using hair dye. So all of you know that hair dye can cause both, that is contact leukoderma as well as it can cause contact dermatitis, that is allergic contact dermatitis. Because this is dermatitis, in dermatitis there is inflammation, so skin becomes swollen, red, there is itching, and the common culprit is PPD, that is paraphenylene diamine. So this is the culprit which causes contact dermatitis. But if there is leukoderma, that is after application of the hair dye, the skin becomes white in color, that can be contact leukoderma, and the culprit chemical which causes this is tertiary butyl catechol. So this chemical can cause whitening of the skin. So as you can see in the image, what they have shown redness and swelling. So all these are the inflammatory changes which are occurring after application of the hair dye. So this is a case of contact dermatitis and the culprit agent is PPD. Here chromate is also there in the option, and potassium dichromate is present in cement, and this can also cause contact dermatitis. Pollens and balsam of Peru, these are plants. So sometimes gardener or the farmers develop dermatitis and that can be due to these plant products. Then 28-year-old female presented with complaint of painless ulcer in the genital area. Now this is very important because this is pointing towards genital ulcer, that is sexually transmitted infection, and whenever patient presents with genital ulcer, remember, look for pain. If pain is absent or if pain is present, it can take you to the answer, because painful genital ulcers are seen in herpes and chancroid. But here painless genital ulcer is written, so obviously chancroid and herpes is not the answer. Now painless genital ulcer can be seen in syphilis, LGV, donovenosis. Now in this, they are further saying that it is associated with non-tender inguinal lymphadenopathy. Now we know that in donovenosis, no lymphadenopathy is seen, instead pseudobuboes are seen. And another name of donovenosis is granuloma inguinale, and because inguinal lymphadenopathy is present, obviously granuloma inguinale or donovenosis is not the answer. So we are only left with one option, and that is syphilis. So in syphilis, painless genital ulcer with non-tender inguinal lymphadenopathy is seen. The genital ulcers of syphilis are very hard and due to firm induration, and the lymphadenopathy is of rubbery consistency. So these are the points, and with the help of these you can reach to the answer. The answer here will be syphilis. If you want, you can remember few more points. Like I told you, in syphilis, hard genital ulcer and rubbery lymphadenopathy is seen. In LGV, transient genital ulcers are seen, and because they are transient for a short duration, patient can develop late complication like groove sign and estheomen. Similarly, in herpes, vesicles are seen, and in chancroid, ulcers with undermined edges are seen. They are generally multiple and they can bleed on touch. But remember that the ulcer of donovenosis is very red, granulomatous, and it bleeds easily on touch. So these are few more points which can help in differentiating these sexually transmitted infections. In the clinical condition shown, what this image is associated with. Now what you can see that over the face of this child, a large black color lesion is present, and this clinical presentation is of a giant congenital melanocytic nevus. Remember that this is a benign condition and it is present since birth, and it is due to benign proliferation of the melanocytes, and melanocytes, you know, is the color forming cells. So these are generally dark in color, and we are calling them giant because it is a very large lesion. And it has been noticed in various studies that this giant congenital melanocytic nevus have malignant potential, and this clinical condition can be seen associated with malignant melanoma. So remember that the diagnosis here is giant congenital melanocytic nevus. A 40-year-old female patient, known case of ovarian cancer, presented with following lesions shown in the image below: difficulty in activity like climbing of stairs, getting up from the chair, combing hair. So all these are suggestive of muscle weakness. So muscle weakness along with skin lesions as shown in the image is suggestive of which condition? Yes, it is suggestive of dermatomyositis, and the skin lesions are sometimes very important. Like you can see Grodden's papules, which are generally seen over interphalangeal joint or metacarpal phalangeal joint. So here these papules are generally present. Then similarly, there is Scholl sign, that is erythema or violaceous presentation over back. And similarly, Around the eyes also, patients start developing erythematous or violaceous rashes, which is known as heliotrope rash. All these are suggestive of dermatomyositis along with weakness of muscles. 26-year-old man presented with erythematous plaque. So they are red in color, they are solid raised areas covered with silvery white scaling. This is very characteristic of which condition? Yes, psoriasis. And it is present where the common site involved is extensors like knee, elbow and back. And on examination, pitting of the nails is also present, which is the most common nail change associated with psoriasis. So what is the likely diagnosis? Yes, obviously this is a case of psoriasis. And these are the characteristic lesions, that is erythematous plaque with silvery white scaling, which is seen in psoriasis. Then a patient presented with itchy lesion. So these are very itchy lesions as shown in the image below, and if you see them closely, all of them are very small lesions. These are papular lesions. So papules are present. If you look at the color of the lesions, they are slightly violaceous or purple in color. They are very small papules, and if you look at the shape of these lesions closely, they are not exactly round but slightly polygonal in shape. So polygonal, and the lesions are not elevated, instead they are flattened lesions. As you can see, this flat lesion, so these are plain topped and they have lot of itching, so they are pruritic. So you can see all these P's are present here: plain, purple, polygonal, pruritic, papules. All these are pointing towards lichen planus. So lichen planus is a condition where such lesions can be seen. A patient presented with multiple painful blisters. So these blisters, these fluid-filled lesions are painful and with erythematous base along a particular dermatome. So they are present along a particular dermatome of trunk as shown in the image below. What is the probable diagnosis? So yes, the lesions are unilateral. They are along a particular nerve segment or dermatome and they are having these vesicles, that is fluid filled lesions. So all these are pointing towards, yes, shingles, that is herpes zoster, which is due to reactivation of varicella zoster virus, also known as shingles. In the next question, they are saying that 45-year-old truck driver presented with a lesion shown in the image below. Now, truck drivers, because most of the time they are outside driving these trucks for many days, many a times, so these are very prone for developing sexually transmitted infection, and he is having multiple sex partners. Okay, so both these are pointing towards the occupation as well as the history is pointing towards sexually transmitted disease. And in this sexually transmitted disease, patient is having such lesions over palm. So do you know of any condition where such lesions develop over palm? Yes, it is seen in secondary syphilis. These rashes which develop over palm are generally dark in color, they are hyperpigmented, and if you press them with any blunt object, they have deep dermal tenderness. This is known as Buschke-Ollendorff sign. So Buschke-Ollendorff sign is seen in secondary syphilis. So this is the answer here. A 45-year-old smoker presents to the hospital with painless oral lesion. This is a white patch which is developing in the oral cavity as shown in the image below. What is the likely diagnosis? Now you know that smoking is a predisposing factor for various malignancies as well as leukoplakia. Here you can see that this whitening is only on the lateral part of the tongue, which is also having these hairy projections. So this is pointing towards oral hairy leukoplakia, which is caused by Epstein-Barr virus, and the common site is lateral tongue. So this is a case of leukoplakia. Unlike lichen planus, where the lesions are not white but violaceous, that is slightly purplish in color, and there can be lacy pattern or reticulate pattern which is seen over the buccal mucosa. In candidiasis, a white membrane is seen over buccal mucosa, and if you rub it, it can be detached. And because candidiasis have a predisposing factor as diabetes, so commonly whenever question comes on candidiasis, instead of a smoker, diabetic patient is written in the history. So all these are pointing towards leukoplakia, which which is the answer here. Identify the image shown below. In the image, what you can see that this is slightly asymmetrical lesion and the borders of the lesions are irregular. As you can see, the color, if you see, is variable. That is, different colors can be seen. It is slightly more dark here, slightly light here. So variable colors are present here. Diameter of the lesion is large. It is more than 0.5 centimeter in size. And if you see, if the lesion is evolving or enlarging, or it is elevated at places, then all these points are suggestive of malignant melanoma. So melanoma can be identified with the help of these points. You can easily remember A, B, C, D, E. That is asymmetrical lesions with irregular border, variable color, large diameter and evolving lesion. Identify the condition below which is shown in the image. In the image you can see that this is verrucous lesion. Verrucous means wart-like, that is rough surface lesions, and it is present where? Over the genital areas. So this is anogenital warts, that is condyloma acuminata, commonly caused by human papilloma virus 6 and 11. While condyloma lata are seen in secondary syphilis, which are generally flat lesions. Like here they are rough lesions. Condyloma lata are flat lesions seen in secondary syphilis. A 4-year-old boy was brought to the clinic with a vesicular rash. So these are vesicles. Vesicles, that is small fluid-filled lesions that covered his entire body. According to the child's present, the rash began with a red patch which quickly developed into the fluid-filled blister. So rash followed by blisters. The child also has mild fever. So there are prodromal symptoms like fever and malaise. Patient is feeling irritable. What is the most likely diagnosis? So in this child's condition, you can see that the patient had fever, malaise, irritable child, and now he's developing rash, and followed by rash, there are vesicles and involving whole body. All these are suggestive of chicken pox, that is caused by varicella zoster virus. So varicella or chicken pox is the answer here. All these lesions have reddish halo around them, and these are vesicular lesions, fluid-filled lesions, which are seen in chicken pox. 45-year-old patient presented with the following skin lesions characterized by red scaly patches. So these are scaly patches which patient is having over the skin. He also complains of painful and swollen finger joints. So joints are also involved. So scaly lesions over the skin along with joint involvement. Do you know of any condition where scaly lesions are seen and joint involvement is seen? Yes, one condition is psoriasis. And do you know that which is the most common joint involved in psoriatic arthritis? Yes, it is distal interphalangeal joint, which is shown in the image. So on examination, the finger joint appears inflamed and tender to touch. What is the probable diagnosis? It is probably psoriatic arthritis, where distal interphalangeal joint is involved. And if you do X-ray, you will get pencil in cup deformity. And the drug of choice for psoriatic arthritis is methotrexate. A patient with history of herpes simplex virus infection presented with fever, uneasiness, arthralgia, which is accompanied by skin lesions as shown in the image on palm, back of the hand, feet, arms, and what could be the likely diagnosis? Now, if you closely see these skin lesions, what you can make out? You can make out that the lesion is having a dark red portion in the center. So there is a central dusky erythema. Now this central dusky erythema is surrounded by slight redness. You can see it is red as well as it is slightly elevated. So this is not just erythema, but this is edema. So edematous ring, which is further surrounded by slight redness, that is erythematous halo. So you can see these are three things which are present in this lesion, that is central dusky erythema surrounded by edema, surrounded by erythema. So it looks like a target lesion, and all of you know target lesions are seen in erythema multiforme. And do you know what is the common etiological factor for erythema multiforme? Yes, it is generally due to viral infections or drugs. Viral infections like herpes simplex virus. So there is a predisposing factor, that is herpes simplex virus infection, followed by target lesions. All these are pointing towards erythema multiforme. 12-week pregnant woman who is already on multi-drug therapy for leprosy. So patient is suffering from leprosy and patient is taking MDT. So for leprosy, patient is taking MDT, multi-drug therapy, presents with a type 2 lepra reaction. So lepra reaction also patient is developing. Which type? Type 2, that is ENL, erythema nodosum leprosum, ENL, type 2 reaction, also known as ENL reaction. What is the treatment of choice in this patient? Now, because the patient is suffering from multibacillary type of leprosy, we will give MDT, and in MDT, if patient develops reaction, we have to give the drug of choice for type 2 lepra reaction, that is steroids. So what do you need to do? You should not stop MDT. Instead, you should continue MDT to treat the leprosy. And to treat the lepra reaction, you have to add steroids, which is the drug of choice for type 2 lepra reaction. So answer becomes continue MDT and add steroids. Remember that in ENL reaction, the drug of choice is steroids, but if steroid is not there in the option, then you can choose thalidomide. Thalidomide is also effective in type 2 lepra reaction. Match the following types of scales with their associated condition. Collerate scales. We have already discussed collerate scales are seen in Pityriasis rosea. Silvery scales, they are seen in psoriasis. Mica-like scales, they are seen in Pityriasis lichenoides chronica. And brany scales, that is very fine powder-like scales in Pityriasis versicolor. So this becomes the correct option. So these are various scales which are seen. Similarly, fish-like scales are seen in ichthyosis. Now, a diabetic female presented with a progressive skin lesion as given in the image below, what is the most likely diagnosis? So, if you see the image, you can see the site involved is upper part of the face and where such erosion is present. And if you look at the margins are rolled. So, this is a rodent ulcer or simply basal cell carcinoma. Generally, when these lesions develop, they are papular and gradually telangiectasia start developing over these lesions, and later they might ulcerate, form such type of lesions with characteristic rolled edges or pearly beaded edges, and such rodent ulcers or basal cell carcinoma, similar is the presentation. A diabetic patient presented with following lesions in the armpit. So axilla is being shown here. In the armpit, patient is developing this lesion. And do you know any skin rash which develops commonly over axilla where Wood's lamp help in the diagnosis? Yes, that is erythrasma. Erythrasma is caused by a bacteria, that is Corynebacterium minutissimum. And under Wood's lamplight, it produces coral red colored fluorescence. So answer becomes coral red fluorescence, which is seen in erythrasma. 8-year-old boy presented to the OPD with weakness in his lower limbs and rash. So there is weakness, muscle weakness is present in the lower limbs along with rash over the eyelids. I told you that a rash which is slightly erythematous or violaceous around the eyelids is suggestive of heliotrope rash, which is seen in dermatomyositis, and biopsy shows inflammation of the muscle, and which finding is shown in the image. And in the image you can see these lesions which are present over these interphalangeal joint and carpal metacarpal joint. So all these are Groton papules. So these are Groton papules, but they have mentioned about heliotrope rash as well, which is around the eyelids. Shawl shine is over the back, which we have seen in the previous image, while scleroderma is totally different and not associated with dermatomyositis. Consider the cause of alopecia. Which of the following causes non-scarring alopecia? So non-scarring alopecia, I'm going to give you one mnemonic here. You can remember all the conditions which cause non-scarring alopecia with the help of Tata Sky HD. That is Tata. So all alopecia is starting with A and T. So like alopecia areata, like telogen effluvium, like androgenetic alopecia, like anagen effluvium, like tractional alopecia, all these cause non-scarring alopecia because all of them are starting with A and T. So answer becomes 1, 2 and 3. Other than this, there are other causes also which start with S, like secondary syphilis, where moth-eaten alopecia is seen, SLE, then hypothyroidism, hyperthyroidism, hypopituitarism, and certain deficiencies like deficiencies of zinc, iron, biotin. So all these are the conditions where you can get non-scarring alopecia, while frontal fibrosing alopecia is example of scarring alopecia. Similarly, in lichen planus also scarring alopecia occurs. Now identify the condition given below. Now in this image, look closely and you will find that there is slightly whitening of the skin and glistening of the skin, that is shiny skin is present, and this is known as porcelain white skin which is developing over genitals, and this is very characteristically seen in lichen sclerosus. So lichen sclerosus, also known as lichen sclerosus atrophicus, characteristically presents with similar clinical presentation. So this is one condition. This is not very common, but still if they ask you that a female patient presenting with symptoms like sometimes there is burning sensation, itching, or sometimes there is problem in the urination, and also there is painful intercourse. So all these are the symptoms associated, and the opening is becoming tight or narrow, and the skin is becoming tight, and there is porcelain white glistening skin which is present over the genital areas. All these are the features which can be seen in lichen sclerosus. A patient presented to the OPD with the following skin manifestation as shown in the image below, which is associated with Raynaud's phenomena. So do you know any condition which is associated with Raynaud's phenomena? That is there is vasoconstriction, and due to which the fingers become very pale. So that can be seen associated with scleroderma. And in scleroderma, there is one very peculiar pigmentation which is seen. As you can see here, few dark and few light spots are present. This is known as salt and pepper pigmentation because there are few white, that is salt colored, and there are few black, that is pepper colored skin changes which are present. All these are associated with scleroderma. So both these combination give rise to the option or the diagnosis, that is scleroderma, whereas this peculiar salt pepper pigmentation is seen. A patient presented with multiple anogenital warts. So multiple anogenital warts are present. So they have given you the diagnosis. The biopsy of these lesions shows squamous atypia, which is a suggestive finding of malignancy, which human papilloma virus type is considered as the high risk. So high risk, you know that the most common cause of anogenital warts is HPV subtype 6. So 6 is the most common. If 6 is not there, we generally choose 11. So 6 more than 11, these are the common causative organisms or the agents which cause anogenital warts, but the high risk is associated with HPV 18. So remember that there is not just one subtype which can cause anogenital warts. There are various other subtypes also which can cause, like 6, 11, 18, 31. Okay, so among them, the high risk is with HPV, human papilloma virus 18. So that's why the answer is 18, because they are asking about the high risk. But the most common is 6. A farmer presented with swelling on the foot. So there is swelling over the foot with multiple discharging sinus. So swelling, foot, sinuses. What is coming to your mind? In the lower limb, under the microscope, granules are present. So granule in the discharge. So I hope you have made out the answer. There is swelling which is present over the foot. These are having multiple sinuses. There is discharge coming out. The discharge is having granules. And this is true regarding which of the following condition? Yes, they are talking about Madura foot, that is mycetoma. And all of you know mycetoma can be eumycetoma or it can be pheomycetoma. Eumycetoma is caused by fungus while pheomycetoma is caused by bacteria. So both bacteria and fungus can be the causative organism of Madura foot, that is mycetoma. Okay, so all these points are pointing towards Madura foot. A farmer presented with a cauliflower shaped mass. This is very characteristic. That is a growth which is a very big and bulky growth like a cauliflower. Where? Over the foot. And why farmer? Because generally farmer develop these lesions after plant injury. They are more prone for plant injury. So after plant injury, a deep fungal infection can occur. And do you know any deep fungal infection where cauliflower like mass or growth is seen? Yes, this is pointing towards chromoblastomycosis. Okay, and microscopic examination shows copper penny bodies. So now this is already confirmed because we know that copper penny bodies are seen in chromoblastomycosis. So answer here is chromoblastomycosis. A 35-year-old female presented with body mass index of 30. So the patient is obese, weight gain is there, presented with a lesion on the neck. And in obese individual, if patient is developing such type of hyperpigmentation or velvety skin where over the neck, that is neck folds, then it is suggestive of acanthosis nigricans. Yes, so acanthosis nigricans. Which of the following is she most likely cause of the above condition? So the most likely cause is obesity, and all of you know insulin resistance and obesity is associated with metabolic syndrome. So answer here is metabolic syndrome because there is underlying insulin resistance and patient is obese with high BMI. Pitting of the nails with subungual hyperkeratosis is seen in, yes, it is seen in psoriasis, because in psoriasis there are various nail changes which can be seen, like patient can be seen associated with pitting over the nail, which is considered as the most common nail change. Similarly, patient can develop oil drop sign, which is also known as salmon patch, which is the most characteristic nail change, as well as leukonychia, that is whitening of the nail, subungual hyperkeratosis, that is thickening of the nail bed, and onycholysis, that is separation of the nail plate. All these can be seen associated with psoriasis, and among them two they have mentioned, the most common, that is pitting and subungual hyperkeratosis. So these are the features of nail changes seen in psoriasis. Then 40-year-old women presented with hair loss. So patient is having alopecia. For the past 3 months, she has a history of COVID-19 8 months back. Okay, so 8 months back, patient had history of fever or COVID-19 infection, and 3 months back, patient is experiencing alopecia. So almost after fever, patient started developing hair loss within a period of 5 months. What is the likely diagnosis? So do you know any condition where a predisposing factor is there, like pregnancy or typhoid fever or COVID-19 infection or any road traffic accident, and after this stressful condition, few months later, generally 3 months later, patient start developing excessive hair loss? This condition is known as, yes, telogen effluvium. telogen effluvium. Why? Because in the hair cycle, anagen phase is followed by catagen, which is followed by telogen phase. And when such thing occurs like COVID-19 infection, these anagen or the growing hair follicles, they prematurely enter into the telogen phase. And because telogen phase lasts for months, generally 3 months, so these hair follicles do not fall off for 3 months, but after 3 months excessive hair loss starts. Like in this case, patient had fever and then after 5 months patient had alopecia or excessive hair loss. So this is a characteristic feature which is seen in telogen effluvium. And remember, in this there is no patchy hair loss. Instead, there is diffuse hair loss. Patient is losing hair follicle from almost whole scalp. So that's why you can see in the image they have not given any one single patch like alopecia areata, or they have not mentioned any swelling like seen in tinea capitis. So that's why the answer here is telogen effluvium. Then Kobner's phenomena is seen in all except. Now, you know what is Kobner's phenomena? It is isomorphic phenomena or development of the lesions along the line of trauma. So what happens in conditions like psoriasis, vitiligo and lichen planus? In all these three conditions, you can get Kobner's phenomena because these are immunological condition, and when patient produces trauma along the line of trauma, the immunological process starts and patient start developing new lesions along the line of trauma. This is known as true Kobner's phenomena. So in all these, true Kobner's phenomena is seen, while in herpes, Kobner's phenomena is not seen. So they are saying all except, so answer becomes herpes. Identify the type of psoriasis given below, and they have mentioned that this is psoriasis, and what you can see in the lesions are erythematous. They are red in color. So a lot of red lesions are present over the body. So do you know any type of psoriasis where almost whole skin start becoming red or erythematous? Yes, that is known as erythrodermic psoriasis. Unlike other types like guttate psoriasis, which is seen in children, here multiple smaller lesions start developing over trunk and it is associated with upper respiratory tract infection. Similarly, pustular psoriasis, here sterile pus-filled lesions, that is pustules, start developing, and in inverse psoriasis, flexures get involved, unlike the normal psoriasis vulgaris where extensors get involved. So that's why the answer here is erythrodermic psoriasis. Now, 35-year-old lady presents with features of malabsorption, vesicopapules over extensors. So patient is developing papular lesions as well as fluid-filled lesions, that is vesicular lesions, and where they are developing over extensors like knee, elbow, back, and they are extremely itchy. Patient is having a lot of itching as well. Duodenal biopsy shows complete villus atrophy. Do you know what this suggestive of? This is suggestive of celiac disease. Yes, so villus atrophy is present, which is seen in celiac disease, that is gluten hypersensitivity. So do you know of any other condition where there is gluten hypersensitivity leading to the skin lesions? Yes, that is dermatitis herpetiformis. So they are talking about dermatitis herpetiformis where there is underlying celiac disease or gluten hypersensitivity, and that's why the patient is having villus atrophy on duodenal biopsy. Now they are saying that there is on histopathological examination papillary tip microabscess. This is again suggestive of dermatitis herpetiformis, and anti-tissue transglutaminase antibodies are also detected, again suggestive of dermatitis herpetiformis. So all the points are in favor of dermatitis herpetiformis. What is the best way to manage? Because there is gluten hypersensitivity, the best way is to give gluten-free diet. So this is suggested as the most important or the treatment of choice. But if they want to ask about the drug, then dapsone is the drug of choice. So that's why here the answer becomes gluten-free diet. This is the best drug, best treatment. But if they ask you the best drug, then answer will become dapsone. So generally what we give both of them together. But if they are asking the best, then the treatment of choice will be gluten-free diet. Male patient presented with granulomatous penile ulcer. So if you recall, just now we discussed that penile ulcer, which is having very red granulomatous base, is seen in, yes, so granulomatous base penile ulcer is seen in donovenosis. that is granuloma inguinale. So donovenosis or granuloma inguinale, here granulomatous, that is red, beefy red, this is the term which is commonly used, beefy red base is seen or granulomatous base is seen in the genital ulcer. Now on right is Giemsa staining, tiny organism of 2 micron within the macrophages are seen. What this is suggestive of? So all of you know that what is the causative organism for donovenosis? Yes, Klebsiella, also known as Clamatobacterium granulomatis. So this Clamatobacterium granulomatis or Klebsiella granulomatis, this bacteria is engulfed by the macrophages, and such macrophages are known as donovan bodies, which are seen in donovenosis. So what they are asking, what is the causative organism? So diagnosis is donovenosis, causative organism is Klebsiella or Clamatobacterium granulomatis, and Clamatobacterium is mentioned here. So answer becomes Clamatobacterium. Young girl. So a child who has pet dog present in the home, and she presented with deep boggy red area where over the scalp with acute inflammation with pustules. What is the probable infection? Now remember that there is one condition that is a type of tinea capitis known as carrion. And what is the presentation of carrion? Carrion is very common in children, young girl. They present with tender boggy swelling over scalp. So you can see this boggy red area which is present over scalp. This is usually associated with lymphadenopathy, and these hair follicles which are present in this swelling, they can be easily pulled out. So patient also have alopecia. So all these points are favoring towards carrion, which is a type of tinea capitis. Now, can you tell me what is the significance of the pet dog here? So remember that in microbiology, you might have read about anthropophilic, zoophilic or zoophilic species. That is anthropophilic, which are transmitted from man to man, zoophilic, which are transmitted from animal to man, and geophilic, which are transmitted from soil to man. So anthropophilic species that is transmitted from man to man generally cause non-inflammatory type of tinea, unlike zoophilic and zoophilic, which are transmitted from soil and animal to man, can cause inflammatory type. So because here there is a pet dog, and from this animal the infection is being transmitted to this girl, and that's why this is which type? This is zoophilic, and zoophilic generally cause inflammatory type. So this species, which is the causative organism here, is inflammatory type of tinea capitis, and carrion is example of inflammatory type, and that's why a lot of inflammatory infiltrate and pustules are also present. So all these are pointing towards inflammatory type of tinea capitis, that is carrion. And what is the probable infection? It is carrion. Okay, so don't get confused with bacterial infection like folliculitis or abscess, because here there is boggy swelling in a child and there is a pet dog, so the fungus has transmitted from the animal to the human, and that's why a lot of inflammation is present, not due to bacterial infection. So that's why the answer is not folliculitis, the answer is what? Carrion. A forest worker or a rose gardener got thorn prick, which later developed into linear lesions along lymphatics. What is the diagnosis? So all of you know about rose gardener's disease. So after rose thorn prick, these gardeners or the farmers, they start developing a lesion, and these lesions involve the lymphatics. So along lymphatics, they form such linear lesions, and such linear lesions are characteristically seen in, yes, sporotrichosis. So this is a patient suffering from sporotrichosis. A farmer presents with swollen foot, multiple sinuses as shown in the image. So if you recall, just now we discussed one more question and I told you that foot with swelling. As you can see in the image, there are multiple swellings and there are multiple sinuses and there is discharge coming out, and in the discharge there are granules. It can be what? It can be Madura foot or mycetoma, which can be caused by both fungus and bacteria. So it can be eumycetoma or actinomycetoma, but this is the common presentation. You can remember this image as shown in the foot, and this also generally starts with plant injury, so very common in gardeners and farmers, and it is commonly seen in the southern part of India. This is what? Mycetoma. Then young adult male presented to OPD with hair loss. So patient is having alopecia, hair loss. As shown in the image, there is a patch of complete hair loss. What is the diagnosis? So all of you know such type of patchy hair loss. Patchy means there is one area which is involved. So there is one area where the hair loss is occurring. So there is hair loss, that is alopecia, and this is involving area, that is areata. So this is alopecia areata. One area or patch is involved. So there is one specified area. This can be a single area, that is a single patch, or there can be multiple such patches. This is a characteristic presentation of alopecia areata. Now, when alopecia areata involves whole scalp, okay, so sometimes instead of patches, whole scalp have hair loss. So that is known as alopecia totalis, that is whole scalp involvement in cases of alopecia areata. But if instead of scalp, whole body is involved, then we call it alopecia universalis. While anagen effluvium is the condition which is seen after chemotherapy, that is the patient start losing complete hair follicles, that is complete hair loss seen after chemotherapy. This is due to anagen effluvium. Now identify the pathology depicted in the image, and what you can see that the patient used to apply bindi or kumkum here, and then she started developing a depigmented patch, and due to which she started applying the same kumkum above it. Okay, so what is happening? The patient is applying some chemical, and that chemical is leading to contact leukoderma, that is whitening of the skin. Leuko means white, derma means skin. So this whitening of the skin is due to contact to some chemical. So this is known as contact leukoderma, and this can be due to various chemicals. There is one chemical which is present in the adhesive behind the bindi, and that is known as para tertiary butyl phenol, and this is the culprit which can lead to this condition, that is contact leukoderma. Patient is presenting with pruritus. So there is a lot of itching which is present. Where? In the web spaces, that is interdigital cleft in the web spaces. And the clinical picture is shown in the following image. What is the diagnosis? So do you know any very itchy condition which generally involves the web spaces? Yes, the answer is scabies. Okay, so dermatitis herpetiformis is also very itchy, but here the lesions are where? Overextensors. While erythema multiforme presents with target lesions, while atopic dermatitis generally involves flexures, and here there are other associated conditions like itching along with family history of atopy is usually present, that is mother having history of asthma. So such clinical history is mentioned. So this is a case of scabies. Patient presented with such clinical presentation, and it is mentioned that patient is on multibacillary MDT therapy because patient is probably suffering from leprosy. Which leprosy? Multibacillary leprosy. That's why patient is taking MB type of MDT therapy. Inflammation and edema over the pre-existing lesions has occurred. So whenever there is inflammation and edema over the pre-existing lesions, this is suggestive of lepra reaction. So patient is of leprosy and MB type of leprosy, and patient is now developing lepra reaction. As shown in the image, the nerves are involved. So nerves also get inflamed. There is neuritis. What is the next line of management? So in leprosy, we know that we give MDT, and for lepra reaction, we know we give steroids. So you need not stop MDT. Instead, you continue MDT and you start giving steroids as well. So this will be the answer, which is the drug of choice for lepra reaction, steroids. The following is the image of multiple warty lesions on the hand. So you can see these multiple warty lesions over the hand. Virus responsible for producing such lesion is human papilloma virus. This is the common presentation of which warts? This is verruca vulgaris, which is the common type of warts, also known as common warts. They are commonly caused by human papilloma virus 2 and 4. So, human papilloma virus is the causative organism. 35-year-old male presented with following hyperpigmented lesion. So, you can see this dark colored lesion which is present. With excessive hair, there is hypertrichosis. That is excessive growth of the hair follicle in this hyperpigmented lesion. So पहले क्या हुआ? Dark lesion. So first a dark hyperpigmented lesion developed and then hypertrichosis, excessive growth over the chest for last 15 years. So patient's age is 35 years and for last 15 years he is having such lesions. So at the age of 20 years he started developing such lesion. That is around his teenage he started developing this lesion. So most likely diagnosis is Becker's nevus. Why? Because Becker's nevus usually develops during teenage. In this nevus, initially hyperpigmented lesion develops, which is followed by hypertrichosis, that is growth of excessive hair follicles. The common site is generally trunk as shown in the image. So the diagnosis is Becker's nevus, but Becker's nevus is not there in the option. Now remember that this word nevus, if you go for the literal meaning of this word nevus, it means birthmark. So remember that most of the nevus are birthmark, that is they are congenital, they are present since birth. That's why we call them congenital nevus. So normally the nevus are congenital nevus, they are present since birth, these are the birthmarks, but there is one exception and that is Becker's nevus, which do not develop at birth. Instead, it start developing during teenage, that is at the age of 20 in this case. This is known as Becker's nevus and this is not since birth. So that's why this is not congenital nevus. This is actually acquired nevus. So this is example of acquired nevus. So this becomes the answer here. This is acquired nevus. Nevus of Ota and Mongolian spot, both these present with bluish discoloration, blue colored lesions. So remember here there is hyperpigmentation and in the image it is brownish in color. So obviously these are also not the answer. Psoriatic patient. So patient is suffering from psoriasis. Shows good response to oral steroids because psoriasis is an inflammatory condition. So if you give oral steroids, the patient responds, but generally we don't use oral steroids in the treatment of psoriasis. Why? Because there can be a rebound phenomena, that is when you taper off the steroids, the psoriasis can aggravate. And that is what has happened in this case, that it has responded well to oral steroids, but on stopping, as soon as you have withdrawn the steroids, he started developing following lesions. And what are the lesions? Lesions are pus-filled lesions. So what happens that when we give steroids in psoriasis, the inflammation subsides and the psoriasis improves. But as soon as you stop steroids, this psoriasis flares up, rebound phenomena occurs and more severe type of psoriasis develops in the form of, in this patient, pustules. So pustular psoriasis. So remember, this is the common presentation of pustular psoriasis, that is sometimes after withdrawing steroids, which have been started by some quack probably, because dermats generally don't use oral steroids in psoriasis. So what happens when we stop them? The rebound phenomena occurs, more severe form of psoriasis develops in the form of pustular psoriasis. How you are going to treat these patients? Pustular psoriasis, the drug of choice is acitretin. And that is the reason why, because this is a teratogenic drug, if this same condition develops in pregnancy, which is given a name that is impetigo herpetiformis. So if patient develops pustular psoriasis in pregnancy, that is impetigo herpetiformis, then the drug of choice is not acitretin. Instead, we give steroids. So remember that sometimes students get confused that generally we don't use steroids, but remember this one indication where if the patient is pregnant and developing a severe form of pustular psoriasis, we give steroids. If a steroid is not there, then you can choose cyclosporin, but never choose acitretin in such cases because it is teratogenic. So which of the following causative organism is responsible for this condition? And what is shown, there are rashes which are present over hand. There are ulcers or rashes present in the mouth. And this is usually associated with such ulcerative rashes over foot as well, known as hand, foot, mouth disease caused by, yes, Coxsackie A. So this is the common causative organism, and here in the images you can see the patient may have prodromal symptoms like fever and rashes because this is a viral condition, and they start developing this rashes or ulcerative lesions over hand, foot and mouth. This is slightly painful sometimes, and you have to give symptomatic treatment to the patient, and gradually this subsides. The image of the lesion is given, which is associated with itching. So there is a lot of itching which is present, and in the lesion you can see this annular lesion. Why we call it annular? Because annular means ring like lesions. Here you can see that in the central the lesion is not very significant, but in the periphery the lesion is present. So such type of lesion is known as annular lesion or ring like lesion because there is central clearing which is present. So do you know a condition where ring-like annular lesions are seen with central clearing? Yes, answer is tinea. And all of you know that tinea is very itchy condition. Okay. But remember that granuloma annulare can also present with annular lesion. So why this is not granuloma annulare? Because granuloma annulare are generally asymptomatic. And there is some predisposing factor like diabetes associated with it, which is not mentioned in the question. So that's why granuloma annulare is not the answer. Why it is not psoriasis? It is not psoriasis because psoriasis have erythematous, similar red lesions, but there is no central clearing and there is a lot of silvery white scaling. And this is not tinea cruris. Why? Because tinea cruris generally involves groin area, genital area, but here in the image, the body skin is being shown, probably of the forearm. So this is what? This is tinea corporis. Infant is presenting with itching and rash as shown in the image. Okay, so this infant is having this itching rash which is present over the face. His mother is asthmatic. Mother is having history of atopy, that is one allergic condition like asthma. So what is the diagnosis? Yes, the diagnosis is atopic dermatitis. What are the important clues? The first important clue is itching, because pruritus is very important feature which is almost always seen in atopic dermatitis. Second important clue is that there is history of atopy in the family member, like history of asthma in the mother. And the third important clue is the site, because normally flexors are involved in atopic dermatitis like cubital fossa, popliteal fossa, but infants or young children, they crawl. So when they crawl, their extensors can also get involved along with face involvement. So this can be seen, that is face involvement and extensor involvement in atopic dermatitis can be seen in young individuals, but later in adults, generally flexors are the common sites. So you can see three important clues which are pointing towards atopic dermatitis: lot of itching, mother having history of asthma, face involvement in infant. So this is atopic dermatitis. 10-year-old child presented with bald patch. So there is alopecia. Over scalp with easily pluckable hair. Now, I already told you that when patient suffers from fungal infection, that is tinea capitis, if you pull the hair follicle, they easily come out. So easily pluckability of the hair follicle is a very important clue towards the fungal infection. So just reading the first point, we know that in tinea capitis, that is in fungal infection of the hair follicles, there can be hair loss, that is alopecia, and there is easily pluckability of the hair follicle. So all these are pointing towards tinea. Magnifying glass shows black spots. So do you know any tinea capitis where black spots are seen? Yes, that is black dot type of tinea capitis. So there is a type of tinea capitis which is black dot type, and here black spots are seen. These black spots are seen, and patient can also have alopecia. So all these are pointing towards tinea capitis. What is the drug of choice? The drug of choice for tinea capitis is griseofulvin. So remember that tinea capitis can be broadly divided into two types. One is inflammatory, like we read the previous question where pet dog was present, and it can be non-inflammatory type as well, like here. Inflammatory types are carrion, where boggy swelling is seen, favus, which is common in residents of Kashmir, and here crusting is seen. Then black dot type, like here black dots are present, or gray patch type where grayish patch is seen due to scaling. Because there is a lot of inflammation here, there can be scarring. So these two are example of scarring alopecia. While here there is no inflammation, so these two are example of non-scarring alopecia. So if you recall, just now we discussed all the examples of non-scarring alopecia. I told you they generally start with A and T. So here also you can see tinea capitis is starting with T. But remember that in tinea capitis, both the types of alopecia can be seen. If there is inflammation, it will cause inflammatory type, that is carrion and favus, and they can lead to scarring alopecia. When there is no inflammation, that is black dot and gray patch type, there will be no inflammation, so no scarring. So non-scarring and scarring both can be seen in tinea capitis depending on the type. Then 28-year-old lady with asymptomatic dome-shaped small lesions are known as papules. So papules on forehead for last 2 months. She has a 2-year-old daughter with similar lesions. So what they want to tell about this condition, that it is contagious. It is spreading from mother to the child. And what is the causative organism? So do you know any contagious condition, any infective condition which can transmit from one person to another, from mother to the child due to close contact and having dome-shaped small lesions? Yes. So dome-shaped small papular lesions, pink pearly papules with central umbilication is seen in molluscum contagiosum. And here you can see these lesions. If you closely see them, you will find that all these lesions have central depression, central umbilication. So this is very characteristic of molluscum contagiosum, and molluscum contagiosum is caused by virus, that is pox virus. So it can get transmitted from one person to another. And if you do biopsy from these lesions, you will get Henderson Patterson bodies. So with this, we come to the end of today's session. I hope this was fruitful for all of you. Thank you very much. All the very best.